Thanks, Dr. Kaliza. That was a great talk. So I've been tasked with having first of all, my name's Anthony Festa. I'm actually a sports medicine doctor, head team physician for Seton Hall. Tasked with evaluating a pretty broad array of injuries. So I'll try to get through this pretty smoothly. I know you guys are post-lunch. So the title of the talk today is Evaluation and Management of Traumatic Knee Pain. I have no conflicts of interest to disclose. What we're going to get through today are discussion of injuries of the four main ligaments of the knee, the ACL, PCL, MCL, and LCL, as well as traumatic meniscal tears and traumatic patellar dislocations. And so ACL is probably the ligament that we all hear about the most and gets the most attention in the media. And Dr. Kaliza talked a little bit about it. The ACL is a ligament in the center portion of the knee. It tends to go from the lateral side to the medial side and from posterior to anterior. Why it's important is it's the primary constraint to anterior translation of the tibia on the femur. We also sometimes forget and don't talk about it. It also has some rotary control of the knee, as well as varus and valgus, which is sort of the side-to-side motion of the knee. When you have a patient who comes in with an ACL tear, after 10 years in practice, I myself am still sometimes surprised. I expect to hear more dramatic stories from these patients. I think the patients are sometimes surprised when they find out they have ACL tears, that their mechanism of injury is often not that dramatic. The majority of these injuries are non-contact injuries where the patient or athlete just plants their leg one way, and they often describe feeling a pop or a tear in the knee. Typically they may not have an immediate effusion, but what I find most patients, they'll see me the next day, and the day of injury they were fine, but the next morning they woke up and their knee was blown up like a balloon, and that's because it was filled with blood. And so one of the things that we're taught pretty early in residency and sports medicine fellowship is the rule of 70, and it holds fairly true, where with ACL injuries, 70% of them are non-contact, 70% have hemarthrosis, and 70% of the patients feel a pop. So when you see these patients, and you start to see a lot of them, you realize when they sort of come in that it's more than just a mild knee sprain. Typically, these patients are on crutches. They're having a little difficulty getting around. They definitely have a limp. Again, the majority of them have fluid in their knee. They often have a hard time moving it. And when you're trying to examine these patients, it's often easy sometimes, when we're covering games as sports medicine doctors on the field, you can get to the patient pretty quickly before the knee swells up and they don't really know what's happening, and you can get a good exam on them to test the ACL. But when you see them a day or two later, it's not uncommon that these patients are guarding. And so, sometimes you just really can't get them to relax to get a good exam. But the two exam maneuvers, probably the one that we use the most sensitive is the Ligament exam, where you basically stabilize the femur in one hand and pull the tibia forward at about 20 to 30 degrees of knee flexion. And you're really feeling for translation, and what you want to feel is a firm, nice stop. It takes a while to get comfortable with it. The one benefit of orthopedics is you have another side. So if you're ever not sure about the exam, it's often nice to examine the uninjured knee so you can get a baseline to kind of figure out where you're going from there. And the anterior drawer is nice if you have a patient with a big leg, and we often encounter this in football players, linemen, where they have these huge legs. You put the knee at 90 degrees, and you can kind of sit on their feet. They sit on their foot and use your hands to pull the tibia forward. Xrays, we typically get often Xrays on every traumatic patient in orthopedics. For the most part, Xrays are normal with ACLs. You often read about the Sagan fracture. It's a little fleck that you see on the lateral aspect of the knee there. It's typically indicative of a capsular avulsion. I'm not so sure. We hear about it all the time. We get tested about it all the time, but it's pretty uncommon, and I honestly can't remember the last time that I actually saw it in one of my ACL patients. If we typically suspect an ACL tear, we will get an MRI. Aside from looking for the ACL tear, we're also looking for any concomitant injuries, bone bruises, meniscal tears. When you look at the MRI in the top left, this is a normal ACL. You see a nice, robust-looking ligament. When you look at it on the right side there, you just sort of see this globular mess and don't see a well-defined ligament. The other thing really to look for too, quite honestly, and I often look for this before I actually look at the ligament, is this bruising pattern here. And so what you'll typically see in acute ACL tears on MRI in the fluid-sensitive sequence, you'll see a bruise in the back part of the tibia, you'll see a bruise in the mid-portion of the femur, and what happens is when the patient tears their ACL and the tibia shoots forward, the back part of that tibia hits the mid portion of the femoral condyle, and it's very, very specific and sensitive for diagnosing an ACL tear. And if you see that, you pretty much know that the patient is going to have a torn ACL when you look at the rest of the MRI. So what you see on the left here, the probe is just hooking around a normal ACL. The yellow sort of you see behind here is just some of the synovial covering on the posterior cruciate ligament right behind it. And this is a pretty bad ACL tear where you see the ligament is just pretty shredded. So how do we treat these? This is not entirely a black and white issue. Not everyone necessarily needs to have their ACL reconstructed. As a general guideline, the younger you are, the more athletic you are, the more you play a cutting and pivoting sport, you're going to get a reconstruction. One, you're getting that for functional reason, because we don't want your knee giving out when you're trying to play sports. But two, we know that people who don't have their ACLs reconstructed and have ACL deficient knees have a higher chance of tearing their meniscus and getting cartilage injuries. So, younger patients who are athletic, they're getting their ACL reconstructed. Older patients who are not active, generally we try more conservative management first with therapy and make them prove to us that they're unstable and are experiencing instability before we proceed with surgery. There's definitely, in this day and age, it seems people are much more active as they get older, and it sort of creates a little bit of a gray area for us. And when we get into the 40, 50, 60-year-old patient who's super active, it's, again, I don't think it's black and white, but, from our perspective, we try to have as good of a discussion with the patient as we can so they understand all the risks and benefits. And so when we do operative treatment, we're generally reconstructing the ACL, meaning we're recreating a new ligament. More commonly, it's tissue taken from the patient, either the two most common being the portion of their patellar tendon in the central third or the two hamstring tendons. Occasionally, allograft is used, and historically, when you look at most of the studies, which are not great, it showed that the results were fairly equivalent. In the past 5 to 10 years, however, if you look at the subset of young athletic patients, there seems to be a much higher failure rate in young athletes who are having cadaver tissue put in. So when you look at this slide, you're just seeing a diagram of different grafts we use. So we have the patellar BTB in the middle here. This is the gracilis and the semitendinosus hamstrings that we'll take and fold over. And some people are starting to talk more about using a portion of the quadriceps tendon, but again, not super common. And so what we do during surgery, we're basically drilling holes into the femur and the tibia. We're pulling the graft into position and then fixing it on either end. Depending on what type of graft you use, there's all different kinds of ways to fix it. On the left, you see a bone tendon bone graft where there's these bullet-shaped screws in. On the right, it's a hamstring tendon where there's almost like a suspensory button on top of the femur. Here you just see an intraoperative picture. This is a patellar tendon graft. You see one strand of graft. And in this picture, you're seeing the hamstrings that are folded over, so you can actually appreciate that there's more than one type of graft there. So with PCL, posterior cruciate ligaments, the PCL sort of runs in a crisscross fashion with the ACL. It goes from the medial femoral condyle to the posterior aspect of the tibia, and its primary role is actually preventing the tibia from going posterior on the femur. And so the history with the PCL is going to be a little different than the ACL. It's a very particular mechanism where there's a direct blow to the tibia. Typically that happens when a patient or athlete falls directly on their tibia with their foot plantar flexed, allowing a posterior directed force on the tibia. You also see it described as a dashboard injury where people hit the dashboard, although in my experience, when we see these motor vehicle injuries, it tends to be more than just an isolated PCL. These patients typically complain of pain in the back of the knee. They have difficulty extending the knee. It's kind of a little more vague history that patients give when they do come in with PCL injuries, and you have to dig a little deeper and examine them a little more closely. It's not quite, your antennae don't quite go up as much as it would with an ACL. Similar with a PCL, you're going to have the patient walk in with a limp. They generally will have fluid in their knee. They don't have full range of motion. They're going to be guarding. You get a sense on exam when they walk in with a huge fluid-filled knee and they're having difficulty bending it. That's when you should be suspicious that there is a structural problem in the knee and it's not something minor. Similar to the ACL, when testing the PCL, it's a posterior drawer. You're going to put generally it helps to sit on the patient's foot. You want the knee at 90 degrees, and you're going to deliver a posterior directed force to the tibia. And, when you're grading these, and the numbers are not so important on this slide because, quite frankly, I think it's really difficult to distinguish millimeters when you're trying to examine these patients. The easy way I was taught and the easy way to grade it is to really just look at the front portion of the tibia and see where it is relative to the femur. And again, you can use the opposite knee for comparison. Generally, the front edge of the tibia sits anterior to the femur. That's going to be a grade 1 or a partial tear. A grade 2 complete tear will be generally flush with the femur, and in grade 3, it's going to go posterior to the femur. And generally, when you're seeing a grade 3 tear, it means that there's more torn than just the PCL itself, and you're often going to see a concomitant ACL tear or posterior lateral capsular injury. Again, traumatic injuries, we're going to get an X-ray. Generally, you hope and find usually that the X-ray is normal on PCL imaging. We sometimes will do stress radiographs in the office just to help grade the tear, although I think these days we probably will rely more on the MRI to quantify the injury. But if you look closely at this bottom X-ray here, you'll notice that if you look at the very front part of the tibia here, this is sitting more anteriorly than this is. And so this tibia is pushed back more than the other one when stress is on it. And so that gives you some hint there that there's an injury. When you look at MRIs, the PCL is a lot more robust on an MRI and a lot more easy to sort of appreciate than the ACL. And you can see this is a normal PCL here. And what you'll see on the MRI with a PCL tear, you'll just see disruption of that normal signal. And this is a really obvious one where there's a tear in the mid-substance. And so, how do we treat these? PCLs are different than ACLs in the sense that isolated injuries, grade 1, grade 2, we're treating non-operatively. We're putting the patient in a brace for a period of time. We're going to start them on therapy, and depending on the grade of injury, usually takes anywhere from 6 to 12 weeks to get back to sports. We're going to reserve surgical treatment, which is, again, a reconstruction similar to that we would do for an ACL tear for combined injuries with a PCL with a posterior lateral corner or multiple ligament injured knee. Or chronic PCLs where we've attempted non-operative treatment and it's failed, and that's really the only option. PCLs take a little longer to recover from, typically 9 to 12 months. The interesting thing about PCLs, and I'll try not to give away who the patient is, but when I was a fellow, we had a NFL player who was an NFL MVP, he was a Heisman Trophy winner, and no one had known publicly that he had torn his PCL when he was in college. And so he went through his entire college career, won a Heisman Trophy, went through his entire NFL career, won MVP of the league with having had a grade 2 PCL tear when he was in college. And if you talk to some of the doctors here, I know some of the guys are the Jets doctors, when you examine a lot of these athletes at the NFL Combine, they pick up a pretty decent incidence of PCL tears in these athletes that were never really publicized. And so, similar to the ACL, we're going to reconstruct the ligament with a graft. The thing that's a little sort of unusual and awkward when we do this reconstruction is we're making a very awkward turn with the ligament. And so it goes, rather than going sort of straight and in line as the ACL does, we're making almost this 90-degree turn to get the PCL in its native alignment. That poses a little bit of a problem. And you talk to most people who fix PCLs, and they're not super common. We never really can make the knee perfectly normal in terms of laxity. The ACL, when you do that surgery, you can make it comparable to the other side. The PCL, it's not quite so easy, and the general thought is you can make it 1 grade better. So if you have a grade 2, you can make it a grade 1. If you have it a grade 3, you can make it a grade 2. And you see here in this picture, this is just a reconstructed PCL there. So the medial collateral ligament, one of the outer ligaments of the knee, not intra-articular. It goes from the medial femoral condyle to the medial tibia. It basically prevents valgus opening of the knee, which is sort of the knock-knee position where the knee goes inwards. Typically, when athletes have this injury, it's going to be a very specific history, and you see it being shown very well in that picture with Cristiano Ronaldo, where the foot is going to be planted on the ground, and there's going to be contact on the lateral side of the knee, pushing it into that valgus or knock-knee position. Patients will usually describe a pop or a tear. The more it tears, the more they will describe that to you. They'll generally be pointing to the medial side of the knee, saying there's pain there. And again, the more severe the sprain, the more difficulty they're going to have with normal activities. Again, these patients will be limping. There will be swelling and sometimes bruising on the medial side of the knee. When you examine these patients, you want to do what's called a valgus stress test, where and you see it very nicely in this picture, you're going to bring the leg to about 30 degrees and put a valgus stress on it and see if the knee opens or if it recreates pain. If you see that that valgus stress test is actually opening the knee in full extension and not only 30 degrees, you need to start worrying that there's additional injuries beyond the MCL. The grading is somewhat important more in terms of outcomes where, and you could use grading system with more ligaments, not just the MCL, but basically grade 1 is going to be comparable to the exam on the other side of the knee. It will hurt, there's going to be a firm endpoint, but the knee really doesn't open up at all. With grade 2, the knee will open up, but there's still an endpoint. There's just an increased amount of opening comparable to the opposite side. And in grade 3, you can basically open the knee up all the way without any endpoint. Typically, X-rays on these are normal. We will get MRIs, and sometimes with the more subtle MCL injuries, if it's not that obvious, it can be somewhat confusing on exam with a meniscus tear. We'll get into meniscus tears in a little bit, but you'll have tenderness on the medial side. So MRI can be quite helpful in terms of distinguishing if it's just an MCL or if it's a meniscus, which can be hard to tell sometimes on exam. But when you look at this MRI, you notice on the upper part, you see a nice robust cord-like ligament, and down here on the MRI, the lower MRI, you don't really see a well-defined ligament. You see some shredding in the middle there. MCLs can tear off of both sides, or they can tear off of the mid-substance. The mid-substance and the ones lower down tend to heal a little bit less well. Treating these, for the most part, as Dr. Kaliza said, we rarely operate on these. They generally always heal well without surgery. It's outside of the knee. It's very well vascularized. Grade 1, we tend to just rest people, maybe do a little bit of therapy, and most athletes can get back to playing somewhere between 1 to 2 weeks. Once you start getting into the grade 2 and grade 3 injuries where there's opening, we'll typically put people in these large hinged braces to control the varus valgus and allow the ligament to heal in a tight position. Grade 2, you generally can get athletes back 2 to 4 weeks, sometimes a little more than that, whereas grade 3s, it can be 4 to 8 weeks. Again, we do not operate on these very frequently. When do we operate on them? In setting of multi-ligament knee injuries where you've torn 3 of the ligaments and you're going in there to do surgery, you will attempt to repair, if not possible, a reconstruction. If you do have a higher grade injury as well that you're trying to treat not operatively and it's not healing, that will also be another option where you'll go in and actually reconstruct the ligament. And then finally, chronic injuries where the ligament never healed and the patient comes in way down the line and the tissue, there's no hope of repairing the tissue, you'll do a reconstruction. So lateral collateral ligaments, very similar to the medial collateral ligaments, they're very uncommon. So in the span of 10 years, 11 years in practice, I think I can probably count on one hand the amount of isolated LCL injuries that I've seen. You see them more commonly in multi-ligament injured knees, patients who are in car accidents, patients who dislocate their knees where multiple ligaments are injured. But the ligament goes from the lateral portion of the epicondyle and the femur to the fibular head. Opposite of the MCL, it prevents varus opening compared to valgus. Similar, it's just an opposite injury, which is very unusual. Again, typically you're going to have a foot planted and the person gets hit on the medial side of the knee, pushing them into the bow-legged position. Again, it's hard to get in that position, and typically you're not going to see it that much. You'll have lateral joint line pain. Again, depending on the degree of the injury, that will determine how physically limited the patients are. Similar to the other exams, you'll have a limp, swelling, tenderness on the lateral side. Exam, it's just basically the opposite of the MCL exam where you're evaluating in 30 degrees and putting a varus stress on the knee. Again, if it opens in full extension, you start worrying that it's more than just the lateral collateral ligament, but that there also may be additional ligaments injured. Similar to the MCL grading system, this one's talking about the millimeters again, but it's sort of similar, where grade 1, you're not going to notice much opening. Grade 2, you'll have an opening but a firm endpoint. And grade 3, it just totally opens without an endpoint. Similarly, again, X-rays typically normal, hopefully normal in these, and the MRI is used to identify the location of the injury, where when you look at this on this, you actually see a low-grade sprain on this upper one. It's not entirely normal, but you do see fluid around the LCL, which is right there. And then on this lower one, you see a mid-substance tear. Treatment, sort of similar to the MCLs, where if you have a isolated LCL, there's not a super large amount of data on this. There's some good studies actually on NFL players that show non-operative treatment for isolated LCLs is reasonable with a good outcome. You also treat them non-operatively initially. If you have an ACL, LCL injury, we'll let the LCL heal first, and then you're going to operate on it with combined multi-ligament injured knees. So to jump to the meniscus, and again, Dr. Kaliza talked a little bit about degenerative meniscus tears. In this talk, we'll maybe focus a little bit more about traumatic meniscal injuries, which just as a whole tend to be less common than your degenerative meniscus. But the meniscus are two semicircular shaped cartilage structures that are on the medial and lateral aspect of the knee. If you think about the knee and why they're important, think about a ball rolling on a table. And so there's only one very small contact point when you have a ball on a flat surface. And it would be a similar case in the knee with the femur being curved and the tibia being flat, where the benefit of having the meniscus in there is it creates a sort of hemispherical cup shape on the tibia and allows the stress to be spread out over a bigger surface area. And so the meniscus is important for load bearing, it's important for shock absorption. It also does play a small role in joint stability. So typically when you're looking at a history for a meniscus tear, when you're seeing traumatic meniscus tears, you're generally going to see this in younger patients. You're going to see it in athletes. You're going to have a well-defined incident that causes the injury. The patients will complain of focal joint line pain. It's a pretty easy history to take. They point kind of right to the spot where the problem is. The patients will often describe difficulty bending or pivoting on the knee, and they may or may not have mechanical symptoms, locking or catching. When you see degenerative tears that was mentioned, like the ones that were mentioned in the previous talk, you typically see this in patients who are 30 or 40 and older. There is no traumatic history. The thing you need to worry about in these patients is arthritis. It's very difficult, if not impossible, in those patients to know if their pain is coming from the arthritis or is some coming from the meniscus. The only way you ever know is if you scope them, but that's also not something we generally rush to do in knees where there are signs of arthritis. The symptoms will be similar in terms of pain with bending and twisting. How do we examine these? There's a lot of exam maneuvers. The most sensitive one tends to be the joint line tenderness test. It's pretty easy. You find the joint line either medially or laterally, and you just press on it. And if it hurts, it's got a pretty high sensitivity. The other one that you commonly see is the McMurray test, where you either start the knee in external rotation, or the tibia in external rotation or internal rotation, and you extend the knee. Classically, the positive test is a clunk, but people also report it positive when it causes pain. So when you're doing an X-ray on these, which we typically will do primarily, obviously we're looking for additional injuries, but we're also trying to evaluate whether there's arthritis or not and how that's going to play a role in treatment. One of the things when we order MRIs, and I didn't put a slide on this, but we're looking for what radiologists will describe as a grade 3 signal. So you're looking for a linear signal that goes to the top or bottom surface of the meniscus. MRIs are not entirely perfectly accurate. You see the linear signal here and here. MRIs are not, entirely accurate, believe it or not. When you look at most studies, the accuracy is somewhere, you see from 75% to the mid-90 range. It actually gets worse in the setting of ACL tears, and if you talk to most docs who do ACL reconstructions, it's not uncommon that you do not see a meniscus tear on the MRI, but when we go in there, we'll find a meniscus tear typically in the lateral meniscus. We use different names to sort of describe these tears. They're not so important. They're just kind of more descriptive to understand the physical nature of the tear. These are some of them. You'll see them described as horizontal, flap or oblique, radial, degenerative, bucket handle where a piece is completely flipped into another part of the knee, and then longitudinal or vertical sometimes. These are just some examples of the tears where horizontal tear obviously speaks for itself. It's sort of in the plane of the joint surface. An oblique tear, again, what it sounds like. And if you notice on the MRI here, you'll notice that the tear comes more to the inner portion. A longitudinal tear, which is more commonly, I think, called a vertical tear, you'll see here is in the periphery of the meniscus. And this we'll show in a second is actually really important and has significant implications for how we treat meniscal tears operatively. A bucket handle tear, again, is when a large piece of the meniscus flips where it's not supposed to be. And you'll notice on this MRI here, there's a portion of the meniscus that should not be there. And you'll notice out here, if you compare it to the other side, there's a piece of the meniscus missing. And then again, you'll notice up here, the posterior horn of the meniscus that's back here is kind of gone and sitting in the front part of the knee. One of the things that this slide is probably the most important in terms of determining how we treat meniscal tears, one of the things about the meniscus, it's got a terrible blood supply. And so when you look at that top slide, that's a dye study showing, the vascular penetration into the meniscus. Depending on what study you read, you see penetration in the meniscus anywhere from 10 to 25% of the periphery of the meniscus. And people refer to that as a red-red zone in the periphery, and then you get to the kind of middle third where it's red-white, and then inner portion white-white where there's definitely no vascularity. And this is important because when we're operating on these, it determines whether it's fixable or not. So certainly if a tear is in the inner portion of the meniscus and we sew it together, it's very unlikely that it's going to heal or heal with any quality tissue that will last the test of time. So it determines whether we do a partial meniscectomy, trim portion of the meniscus out, or whether we do a repair. And so when determining how we treat these meniscus tears, typically for degenerative, non-operative types of tears that you're going to see in older patients with more complex tears, we tend to treat these non-operatively at first and do that with medication, whether it's anti-inflammatories, cortisone shots, gel injections, physical therapy. And we're often very hesitant to rush into operating on these people, particularly if they have arthritis, because it's unlikely that it's going to resolve all of their pain. It's usually only a last option when everything else has failed and the patient is clearly having symptoms from the meniscus. What are the ones we operate on? Ones that tend to be traumatic, younger patients. You're generally almost never going to leave a meniscus tear alone in a patient who's in their teen 20s or 30s and having symptoms from that. Again, whether or not we trim portion of the meniscus out or repair it is heavily dependent on the type of tear and the location. When we do operate on these and we do trim the meniscus out for the ones that are in the avascular portion, our goal is to remove as little of the meniscus as possible and at the same time creating a smooth edge. Historically back in the 70s and 80s, if you had a meniscus tear, the thought was the meniscus was like an appendix and it used to basically get cut out. And it wasn't until I think it was the mid-80s that a guy named Fairbanks did a fairly large study that he started noticing that a large portion of his patients were all getting arthritis after he cut their meniscus out. And it's when they really started theorizing that it played an important role. So the benefit of doing it arthroscopically is we're able to be very selective in terms of what we're taking out. So when you look at this diagram here, what you're seeing is this sort of a small oblique tear here in the inner portion, which is not in a vascular area. And we're going to go in there with the camera and just trim that little piece out and again try to recontour the inner edge so it's nice and smooth and stable, putting it at low risk for tearing again. And on the opposite realm, when we do repair these, there's a lot of different ways we repair it and different techniques we use. Not super important to go over all those, but essentially what we're doing is putting stitches in the meniscus to sort of hold it to the periphery. And again, there's ways we do it with large needles. There's now all these fancy devices that cost a lot more money that the companies love, but they seem to be fairly equivalent. But our goal is to try and close down the tear and allow it to heal. And again, the more peripheral it is, the more likely it is to heal well with good tissue. And then finally, the last thing are just patellar dislocations. The patella, when you look at the bony anatomy of the patella, the bone does play some role in stability. So if you look at the kneecap or the patella, the undersurface is shaped like a V. It sits in this V shape in the femur. And once you're past 20 to 30 degrees of knee flexion, that bone plays a super important role in the stability. Before that, the knee is really reliant on a ligament on the medial portion of the knee called the medial patellofemoral ligament that we frequently just call the MPFL, and it prevents the kneecap going lateral. Sort of think of it like a rope tied at two ends that has some slack in it, and in those first 20 to 30 degrees, it's responsible for the kneecap not going out laterally. The ligament originates on the medial aspect of the femur and attaches to the superior one-third of the patella. The history with these tends to be an injury where the patient's foot is planted on the ground and the whole leg externally rotates. What happens is the quad tries to stop that from happening and it kicks the kneecap out. It almost is always predominantly lateral. The only medial dislocations I've ever seen are people who are post-surgery for their kneecap and their mechanics were altered and it allowed them to come out medially. But generally, as a result of trauma, it's almost always lateral. These sometimes tend to be subtle, so it's more common that patients will sublux and not come all the way out, and they'll come in and kind of describe a very vague history that is always not very obvious. It's obviously nice if they're totally out and they go to the emergency room. It makes your life a lot easier. But people typically will complain of anterior knee pain. They'll say that their kneecap feels unstable or that they felt their knee dislocate. And sometimes people have a pre-existing history of instability. When you look at the exam on the top picture, you see that the kneecap here is dislocated at that point. If you're in the ER or maybe in urgent care, you may see that, but more often than not, by the time it gets to the office, it will be reduced. When you examine these patients, you'll see tenderness over the ligament on the medial side. You will often see an effusion. On exam, what patellar apprehension is when you take the patient's kneecap and actually push it laterally. The patient will get very nervous and scared that it's going to dislocate. You also notice in those patients that you can actually push the kneecap further than you can on the other side. One of the measurements to sort of analyze bony alignment, and I don't want to go too deeply into this, but you often hear about the Q angle. It's been something that's been measured for a really long time, and it's a line that's drawn from the anterior superior iliac spine to the kneecap, and then from the kneecap to the tibial tubercle. You see the limits of normal there. This used to be the way people would determine if people had bony malalignment. So if someone was very knock-kneed, that Q angle would be very high. And so just repairing the tissue in those patients usually wasn't thought of to be enough, and I'll show in a minute what the other option is, but it was thought when those patients had bony malalignment, you needed to do a bony procedure instead of just soft tissue procedure. So, again, when you look at the X-rays on these patients, they're mostly normal. Occasionally you will see a small chip of bone that comes off of the patella, and typically, I myself, and I think most people always order MRIs on patellar dislocations. Reason being, you want to see if there's a loose body or piece of bone or cartilage that was damaged. One of the things you'll see on MRIs on the axial view is you'll see this very specific bruising pattern of the kneecap here and the side of the femur, and that's because the kneecap pops out laterally. And you can imagine it's very easy for a piece of cartilage or bone to get knocked off on that edge of the patella or even on this side of the femur itself. When you look on the lateral side, you see how robust this tissue is, not quite so robust here, and you see some tearing of the MPFL there. It's really obvious on this side where you see some discontinuity here of the ligament in that portion. One of the things, I just put this in there because you guys may see this on MRI reports or CAT scan reports. People have more or less abandoned that Q angle I was talking about and now really rely on this thing called the TTTG, tibial tubercle trochlear groove distance. It's just basically measuring the offset of the middle of your trochlear groove here on the femur to the center of the tibial tubercle. And it's a little bit more of a reliable way based on imaging to analyze bony alignment. And when it's more than 20, we're going to start doing a surgery that's not just soft tissue but also bone. So when you look at this, you look at this MRI, typically first-time dislocations we're treating non-operatively unless we get the MRI and see there's a loose body floating around. At that point, we're going to go in, remove that loose body, and do a repair on the ligament. But typically, first-time dislocators, we're bracing for about 6 weeks. The redislocation rate's all over the place on studies, anywhere from 15 to 50% at 5 years. When we do operate on these, we're generally operating for first-time dislocators with loose bodies. We'll go take the loose body out, try to repair the ligament. Otherwise, we're doing an MPFL reconstruction similar to ACL, PCL. We're actually reconstructing the ligament, and you can get a nice shot of that here. When patients have bony malalignment, aside from doing a soft tissue procedure, we're going to add in a tibial tubercle transfer, where you can see we actually cut the tibial tubercle where this attaches, and we shift it over medially, and you get a nicer shot of it here. And we're actually correcting the bony malalignment. So I know there was a lot to take in. It was a pretty broad topic there, but I don't know if anybody has any questions. Had enough? All right, good. Thank you.